Hi, I'm Lori from HIS Talk. Welcome and thanks for joining us for today's webinar entitled Just Step on the Scale, Measure Ongoing EHR Success and Focus Improvements Using Simple but Predictive Adoptive Metrics. It's supported by the Breakaway Group, a Xerox company. Attendee phone lines have been muted to prevent background noise. You can use GoToWebinar's questions box in the console to submit questions to our presenters at any time. The presenters will answer your questions during Q&A at the end. Today's webinar is being recorded, so you'll receive a link to the recording as well as a PDF version of the PowerPoint presentation in a follow-up email. We have two speakers today. First up is Heather Haugen, PhD. Heather's the CEO and Managing Director of the Breakaway Group, a Xerox company. Joining Heather will be Jean Thomas. Jean is Vice President and Chief Information Officer at Memorial Hospital at Gulfport in Gulfport, Mississippi. And with that, I'll turn it over to you, Heather.
All right, perfect. Thank you, Lori. Always so appreciative of the process and how well you all do this at His Talk, so genuinely thankful. We are going to spend a little bit of time today talking about measuring where we are from an EHR adoption perspective, and we use the step on the scale as a bit even of a directive in healthcare, as you know, this is something we need to be doing as healthcare organizations. So most healthcare organizations today have installed and are using an electronic health record or on their way to doing that. And yet many of us are not sure how we're doing or how well we're doing as we move along that process. And so Go Live is one of the milestones, and yet there's a lot to be done still, of course, in using these systems well and really ensuring that patient care is impacted in the way that we want it to be as healthcare leaders. So that's what we're going to spend a little bit of time talking about today. A couple of introductions. I am Heather Haugen. My background includes stepping through academia and the private sector all at the same time. So I still teach at the University of Colorado, which is the medical school here in Colorado. Pretty attached to informatics and research, and so that's where my passion lies. At the same time, I lead an organization called the Breakaway Group, which was founded in about 2000, and we've been very committed to helping healthcare organizations ensure that they use technology well, that there's clinical benefit, and that we're really giving time back to clinicians for patient care. So that's what we do here, and I'm going to let Jean actually spend a little bit of time talking about his role, and more importantly, for the webinar, for he and I, is, you know, what is that story that Memorial has been through as they have gone through their EHR adoption and even beyond that to analytics.
Great, thank you, Heather. So my name is Jean Thomas. I'm, as introduced, the Vice President and Chief Information Officer. And actually, we now call ourselves Memorial Hospital and Physician Clinics out of Gulfport, and I'll explain why in just a second. I stepped into this role about 8 years ago, got into healthcare about 15 years ago. Prior to that, I call myself a recovering technology executive from the 80s and 90s, and got into healthcare naively, not realizing how fragmented it was and how difficult it was to bridge that gap of fragmentation from a technology perspective. Nonetheless, it's been an exciting time, and we've got a lot to share with you today, I think, on that topic. We are a 445-bed not-for-profit hospital on the Gulf Coast of Mississippi. We're wedged between New Orleans and Mobile, Alabama. We own 85 clinics in our market, and that's what I talk about now, why we call ourselves Memorial Hospital and Physician Clinics at Gulfport. Part of that clinic acquisition, that clinic strategy, was both strategic, but started right after Hurricane Katrina, because what happened, the direct hit of the storm actually was right here in the geography of South Mississippi. And a lot of physician practices went away. And what I mean by that is the patients went away, or their building, quite literally, or both. And so it kind of initiated our path to acquire physician clinics and own them outright. About more than half our medical staff is employed. So I kind of build this story that we're kind of clinically integrated within ourselves. So with that footprint, we'll do about 500,000 ambulatory visits this year, about 200,000 outpatient procedures, about 80,000 ED visits, and about 17,000 admissions. What we recently did, which was 15 months and 8 days ago, As we switched to electronic medical record systems in our inpatient setting, our clinic footprint, and our ED. So we had all scripts in our ED, all scripts in the clinics, and McKesson on our inpatient side. For a variety of reasons, meaningful use-driven, and most importantly, to have an integrated system, we decided to look and see what the market had. Did a vendor selection and very quickly centered around a fully integrated system and selected Cerner as our integrated platform. So on June 14th of last year, we took close to 60 solutions, and overnight we switched from 3 legacy electronic medical record systems to a full footprint in almost every venue except for one. We switched to a complete Cerner Millennium footprint literally overnight. And we're 15 months in, and people ask me how is it going, and my standard answer at this point is it depends on who you ask. And so there's a lot we can talk about, and I think Heather's going to comment on what it takes to do adoption. And I know this is called stepping on the scale, but I think we kind of jumped on the scale heavily, and even we were surprised at the heavy lift of doing such a large scale, big bang go live, although we would still say it is the right way to go as opposed to staging this out over time. So maybe, Heather, there's a little bit of introduction I can fill in if you'd like me to anywhere.
Yeah, absolutely. I think that's. I think it's important that people understand kind of the complexity of those, and there are many healthcare organizations that are facing some similar choices that they need to make today around switching either EHR vendors due to strategy, functionality, and some of those things. We'll cover that a little bit today, but I think Gulfport's story is an important one, especially as you kind of navigate here through adoption. So thank you, Jean. So one of the things that we have seen, of course, as healthcare leaders is this dramatic increase in use of electronic health records. This is in the literature, doesn't surprise anyone how far we've come. And yet I think because we live it day to day, I oftentimes want to show this slide because we sometimes forget how far we've come. That 40%, 47% increase in use of even a basic EHR is pretty impressive. When you look at the amount of work that has to go into this across organizations. And of course, more and more organizations are moving towards comprehensive functionality and using that. And yet, there still tends in most organizations to be a gap between something that's installed and something that's used well. And I think that's the place that most organizations get to, in this time frame post-go live, is an understanding that yes, we have it, and yes, it's being used. We're not using paper any longer, but we confuse the terms a little bit of adoption and implementation, thinking that simply because it's installed, it's being used well. And so just the more complex functionality, CPOE and clinical decision support are definitely the functionality that drive quality and safety. And yet, as organizations, we're still struggling to get clinicians to use those. And I don't say that in a way that's blaming, because I don't think it's a clinician issue. And I've gotten to a place, based on our research, that I don't believe that clinician resistance is the primary driver here. I do believe that there are things that we can be doing as organizations to improve this. And it's not that people don't want to go there. It's oftentimes that we haven't prepared well for it and given them some of the right tools and technology. At the same time, the will to do this is very important. I know that's something that Jean will talk about too, is culturally we have to drive adoption also. And we have to give people some of that reason and expect that they'll come to the table and get this done also. So we use an analogy oftentimes to differentiate between implementation and adoption, and it's fairly effective because most people can relate to a wedding, which is a little bit like go live. And Jean, you put on a heck of a wedding at Gulfport when you guys went live with 60 applications. And so that go live event and the success of that actual event is a critical point in organizations, and it's a point where the confidence of users is kind of teetering on, is this going to go well or not? And so very important milestone in our journey. And yet I tell organizations based on the work that we've done that it's just the beginning. There's still a lot of commitment. There's still a lot of communication, governance, and process that has to happen in order for these systems to be used well. So we're in this lifelong and it's a pretty significant commitment. Do you want to talk a little bit, Jean, about some of the things that you did at Gulfport to really ensure not just that the go live was successful, but some of the things you've been talking about as a leadership team around the long-term commitment that was required here?
Yeah, no, Heather, I can talk specifically to that in our journey, and it somewhat parallels conversations I've had with some of my colleagues, even pre and post our go live. But you know, when we decided to go down this path and made the decision to do two things: go with a fully integrated system, and then do it all at once. We had pretty significant discussions as a leadership team that said, you know, vendor agnostic. If we don't have the organizational and leadership will to see it through, we shouldn't do it. Because there will be, it's kind of innate in these systems, there will be disagreements, there will be design decisions, there will be some people want to protect their area, there will be people that don't agree with the process or the functionality or the change. And if we don't have the organizational fortitude and the will to broker those disagreements and those decisions, you shouldn't do it. Because 50%, and this is just my personal kind of opinion, 50% of a EHR implementation, certainly of any scale, has very little to do with the vendor. It's vendor agnostic, frankly. It has everything to do with the organization. And while the vendor is important in the software and the functionality, and those things are critically important, if that's not married up with that leadership and that organizational commitment, I think it's fraught with potential failure. And so we tried to put governance in place. We tried to make sure we had physician governance in place and leadership in place and cross-functional teams that actually work through design decisions and quickly bubble to the top the differences that people may have, either in functionality or workflow or whatever it may be. There's many topics. So you've got to have some process in place where you can put those into a funnel, have people digest it, and somebody ultimately has to make a decision. And we all know how this goes, right? It's not important everybody likes the decision. It's important that everybody understands it. And so we tried to do that as best we could. You know, go live is one of those pivotal points. It's kind of you build up, you build up, you build up, you go live. And in some cases, you got to think that's it. Well, Heather will tell you that's far from the truth. That is just the beginning. And that's where you've got to get your second wind on that organizational leadership and discipline to keep going, because that's when the real work begins.
Yep. Absolutely agree. And the other thing that we have seen is that the activities and even the way that we govern and lead is probably slightly different and needed to be different post-go live. And so organizations are scrambling a little bit with that, but learning, you know, what's required, what that role definition is. And I know, Jean, you and I are going to talk a little bit as we get to some of the other metrics here around some of the work you guys are doing in that area. But I would also say here that oftentimes organizations think that this is going to be perfect or easier or something after go live, and we're pretty hard on ourselves, I think, in healthcare, and thinking that you know, we're not doing it well. And so one of the other reasons why we're going to talk about stepping on the scale is because it's much easier to begin to measure some things to figure out where you are and have a better picture of how it's going. All organizations, whether they're willing to admit it to you or not, are struggling some with this because it's enormous change that requires some real process. And we're seeing a fair amount today, and it kind of fascinating switching of EHRs. Dramatic increase. If you look at 2010, you know, 63% of organizations were replacing paper, and today 60% of organizations are replacing their commercial EHR. Now, this is driven by many things, and we use the word divorce a little bit in jest here, but purposely too, because you know, I think we don't always appreciate how challenging this is going to be. But the drivers of EHR replacements are everything from, you know, more functionality to interoperability strategies to acquisition and merger reasons. So there are very good and legitimate strategic reasons to switch out an EHR, and know that the next one comes with its own set of challenges that are not solved necessarily by having a new EHR. And sometimes the things that we were kind of hoping to get, we're not even sure we realize after a second implementation of an EHR. And so back to the point that Jean made, this is strong reinforcement that we've got to look internally at some of the other things that we can do, not to let all of the vendors off the hook. I mean, we have to deliver in these ways, and at the same time, this is an enormous change that happens in an organization and requires that level of organizational structure. So some of the challenges of EHR replacement have been really interesting. This is the new area that we are really concentrating on from a research perspective. I didn't mention this, but the Breakaway Group was actually founded on the research, and this is the area where I think we need to better understand as a healthcare industry what's going on here. The first thing that I would say is that most organizations that switch out an EHR move from an electronic to an electronic system. They believe that's going to be easier than paper electronic, and our experience has been that it's probably dramatically harder to get there. And there are a couple of reasons why. One is we often overestimate the adoption of our current systems. If we've had them long enough, we kind of tend to think that time is what equals adoption. And the truth is sometimes time is what erodes adoption, turnover of employees, and changes in the actual system and upgrades. We also assume that the communication and the governance structures that we put in place last time we did this will be enough to handle the change that's coming our way. And I think we're hopeful here because we're very busy in healthcare. We're actually a bit overwhelmed with the multiple responsibilities that we have. This is an interesting one, and one I laugh about often, and Jean and I have had a few chuckles about, and that is that the system that you had, which people complained about to some degree, is the system that they want back when they get the new system. And so they are clamoring for the system that they were comfortable with. Not that they loved necessarily, but that they were comfortable with. The changes in workflow and process are always difficult, even if people believe that they're the right thing to do. So this goes back to the idea that change is hard, even when we agree that change is needed. And so that lack of leadership's understanding of even the commitment to conversion, electronic to electronic, which I think, Jean, you guys had a fair amount of experiences with, and since you've done some of this work, this is probably the perfect place for you to talk a little bit more about that.
No, you're right, Heather. I agree with those comments. You know, in talking to other colleagues that have done this, seemingly paper to electronic is easier than electronic to electronic for some of the reasons you mentioned, obviously. And I'd say the biggest one is the comfort level. They're used to it. The clinicians can get through their encounters. They can get through their day. When you change to something new, let's all be realistic, right, which is obvious, but it's amazing how many people don't perceive it as obvious. There is going to be a learning curve. And so I would tell people that are converting in any form or fashion, don't be naive to the learning curve. It's going to happen. And so when you're going from electronic to electronic, you're taking people that are used to using a system and electronic documentation, CPOE, and orders and things like that, and discharge summaries, and they're used to that. And all of a sudden, you're going to change that. And so most humans don't like change. There's going to be what I call kind of a penalty phase where some production is going to go down while people learn new systems. And that's where it'll dovetail back to your pre-go live activities of the discipline of training, not only on this function of the system, the basic navigation, but training on the workflow. And so those things are important. That transition's important. Now, in our case, transitioning to an integrated system had some really instantaneous day one benefits of every patient is charted in one electronic medical record as opposed to multiple. Huge, huge advantage in terms of patient experience and patient care. Big change in workflow, and some people even had to learn what I call the nuances of an integrated system, which again was changing the way they did things. All of a sudden, MedRec, to get very specific, instead of MedRec doing a MedRec on the patient's med in one venue of setting like just inpatient or just the ambulatory setting, now you're seeing patients across the continuum. So those are the kind of things that you got to spend time thinking about and figuring out how to train to and then address after go live. But back to that learning curve, I'll go back and say make sure everybody acknowledges up front there's going to be a learning curve when you convert to something like this.
Yeah, and it takes some time for sure. So despite the research that we did earlier in 2009 was really about this paper to electronic transition. But the truth is that it probably applies really well even to these electronic transitions. And that is that implementation and adoption are not the same. And we have to focus on go live at a point in the timeline and then move beyond that and really understand what the other aspects of this are. And I think it's a little uncharted territory for organizations to figure out the kinds of things they should be measuring and the kinds of things that they should be doing, 15 months, 24 months, 3 years post go live. For sure, leading adoption is still very important. Most of us have learned that this is not an IT initiative, and despite the fact that in healthcare once in a while we still want a person to be responsible for the success or failure of these very complex systems, that is a misnomer and probably just another sign that we're not doing some of those things very well. But leading adoption is a team effort. Especially when it comes to involving the clinicians. Most of us have learned that lesson fairly well. And traditional training methods are one of the things that sometimes impact whether or not we can adopt the actual systems. And we continue to work to ensure that users are proficient in those systems. Metrics, which will be the focus from here on out of the presentation, are one of the things that we should be really looking at. And I think sometimes we get pretty focused on those quality and safety and really important metrics clinically and financially, and we miss whether or not we've actually adopted the system. So we'll talk a little bit about that today. And then, of course, we've been talking throughout about the sustainment that's really required for the life of the application. Is we've purchased something that we now own as an organization and are committed to ensuring that it is a tool that we use well to provide care in our organization. And I think we miss that once in a while. And I hope that more and more healthcare organizations are getting back to, how is this impacting care and my interaction with the patient and the information that I have about that patient. So step on the scale, part of this comes from an interaction that I had with Farzad when he was leading the ONC. And as most of you know that have heard him speak, he's incredibly passionate about data and analytics and measurement of those things. And he brought that to a conversation that he was having with a large group of healthcare leaders. And one of the things that he said is we don't have the ability in healthcare to step on the scale, and stepping on the scale is important. I would take that a little bit further and actually say that we are not sometimes even sure which scale to use to measure some of the things we're looking at around healthcare and how EHRs impact the care process. The other thing is that once the results come up on the scale, oftentimes we're not exactly sure what to do with those results and how meaningful they are in our healthcare organization and what we're going to do with them going forward. And third, sometimes we just don't believe the number. So a few of us have probably stepped on the scale at times and said, nope, there's no way that's right. And we hear that in healthcare organizations. And so this scale metaphor will help us think through a little bit some of the areas that we should be focused on from a measurement perspective. And then one more kind of story about the power of data. I had the good fortune earlier in my career to do some multi-center trials in a clinical setting, and specifically in the ICU. And one of the things that was true, at the time I was working actually as a dietitian, clinically writing TPN orders and things like that for very ill patients. And we had a hypothesis. I was working with a cardiovascular surgeon, and we believed that feeding patients early in their stay actually improved their outcomes dramatically and improved their ability to get off of a actual intubation or a lung machine. And when we did the research that was multi-center, the results were really compelling and actually suggested that that was true. And there was other literature to suggest that also. And so we started encouraging our clinicians to write TPN orders early. And they hem-hawed around, and most of them didn't do it, and they didn't change their behavior. And then we started posting the results of the cumulative caloric deficit for those patients on the patient's door. And suddenly, they started asking for TPN orders to be written. And so when you see the tens of thousands of caloric deficit that a patient is in, it actually begins to change your behavior. So this isn't ever a dig at clinicians. I think they had much more important priorities for some of those critical care patients. And yet, data was the driver for a behavior change, not necessarily a published study or something in the literature, but really data from their actual patients was what was leading to that change that we were talking about. So I'm going to move to the next slide. And Jean, I think this is an area where Gulfport really deserves some kudos around some of the things that you're doing here. And this slide builds, so you may have to tell me how to click, or you want me to click it all?
You're good right there.
Okay.
Before I come on, I want to just back up, Heather, to your story there. You know, what you hear all of us probably listening and talk about is getting the right information in front of the clinician or the physician at the right time. So posting something on the door, that metric that you posted, was an example of that. We're trying to replicate that, right, in the digital world. And this question, there's so much data, how do you do that? And how do you do it without getting information overload? But I think that's a great example of what we all try to accomplish. You just had to do it in a very analog method, right?
Right. And prior to HIPAA.
Yeah, good point. So on this is kind of a story, a slide I use to explain to people the large picture, what we're doing, why we're doing it, and how we do it. So, you know, what I like to say is we want to provide, people like me, CIOs, want to provide, you know, data warehousing and sophisticated clinical and financial tools. So what you really want is that clinical and business intelligence. Well, how do you get that? So Heather, if you'll advance, what you do is you apply analytic tools to get that clinical and business intelligence. But what do you apply that analytic tools to? Well, Heather, if you'll go one more time, you apply those analytics tools to data that ideally you have in a data warehouse or warehouses, depending on your footprint. That data has to be, of course, of high integrity, projectable, and either real-time or near real-time. So how do you get the data in a data warehouse? Well, Heather, if you'll advance for me, what you do is you install systems. Not just install them, but install systems with high use, right? A system installed without use doesn't get you the data. You install the systems, get the functionality there, the training, the adoption, so that you can then, Heather, if you'll click one more time for me, capture the data, to put into the data warehouse, to apply the analytics tools to get your clinical and business intelligence. And this is kind of the content I try to communicate to those people that understand, why are we doing this? What's the big picture? We need that clinical and business intelligence. Yes, you need that at points of care. You need it per encounter, but you need it holistically as well when you're trying to do things like population management and data mining on certain outcomes and looking at cost per case and looking at risk patients. So you need to have that data. This is a real important part, in my opinion anyway, of why we put in electronic systems. It covers the gamut of what does a physician or clinician need at that point of care? How do we make sure we got the right patient information at the right time without having to post something on the door like Heather did? And then how do you go and manage holistically a population of patient or a population of conditions? So this is a story that we like to tell, that I like to tell, of what we're actually in the process of building here at Gulfport.
Yeah, and Jean, one of the things that might also be helpful for this group is, I know you've taken, you know, a strategy of, you know, Cerner and an analytics partner, and, you know, sometimes we think that we can get all of this in one place, or we're not exactly sure how some of these things integrate well. How has that worked at Gulfport, and has it worked well for you?
It has worked well, and this is where I take the converse of some of the comments that some people use. This is where, in my opinion, putting all of your eggs in a few baskets is better. I wanted the integration and have as few foreign systems and as few ancillary systems as possible. I know this gets a little technical, but it is problematic when you have to manage multiple vendors and multiple version controls and what their product strategy is over time. So we really centered around two key vendors: electronic medical record with analytic capabilities, and an EDW, Enterprise Data Warehouse vendor, with analytic capabilities as well. And those are really our two go-to strategies long-term for clinical intelligence and business/financial intelligence. We really tried to coalesce around those two vendors to make it as holistic as possible. And to one of your points, so we can give data to people in procedural areas even before go live, right? So they can measure where was I before go live, and what does my data look like now, whether it's revenue and usage reports, whether it's turnaround times, whether it's door-to-doc time. All of those things we wanted people to have a feeling of before go live, so that at go live they could instantly be more attentive to the deviations.
Yep. Well done. So identifying the gaps in how well we're doing organizationally or stepping on the scale has to cover a lot of different areas. And I think we jump really quickly to clinical outcomes, and sometimes we do financial outcomes, and sometimes that also gets overlooked in an organization, and how important that is actually long term. And you know, the big data term is being thrown around. Sometimes those of us on the opposite side use the word small data, because I really want data that is relevant to our healthcare organization. That means that we can take specific action, and if that is a start with a few pieces of data that we analyze and interpret really well, that's a much better place to start than reams and reams of information coming from somebody who really likes data. So we start even with the engagement of leadership. So that is number one. If you look at the predictors of organizations who do well at adoption and those that are challenged, this is the number one predictor. How well we communicate, govern, organizational will, which Jean talked a little bit about earlier in the presentation. And then in the previous slide, Jean used the with high use. So folks have to be using the actual system and using it well in order for us to then go measure things like important indicators for CPOE or clinical decision support. And it's interesting, I still often hear people say to me, well, we don't have any paper. And so I know that people are using it. So using it and using it well are pretty different. We'll talk in a few minutes about observing users in actual systems, and sometimes that's a shocking experience. But workflow drives how well a user uses that system and how well they understand the system and how it's being used to accomplish a task, which is what we're trying to do with it. So there is this, kind of retraining based on our understanding of how proficient people are and what's going on in the organization and what's changing. Another word that we probably overuse a bit right now in healthcare, and especially healthcare IT, is workflow analysis and redesign. When this is done well, it is really done at a pretty micro level. Observation, documentation, rework of that, and an iterative approach to it. I think folks sometimes, make small changes to things in the system and sort of think that that's workflow redesign. But this is really about the users and the human factors and the processes that we go through to accomplish a task. And a good reminder for all of us that work in this field is that as a physician, what I really want to do is place an order, or what I really want to do is document care. And so just don't forget what my end goal is as a clinician and what I'm trying to accomplish with the tools that I'm using. Clinical and financial metrics, of course, very important. And again, just a recommendation to start at a level that you can actually digest before moving on. Change management before and after go live. This is just a point we just continue to drive home, is what does that governance structure look like, and who's doing the work post go live. It's not uncommon, and I was sitting with the CIO about 2 months ago that said we had done a really nice job of spreading the responsibility, communication, and accountability for our EHR pre-go live, and after go live it all fell back in my lap. And that's really common because we have so many priorities in healthcare, and oftentimes someone has to stand and receive the other things that are coming in post go live. So that structure is really important. And then user satisfaction over time, just ensuring that we're having the conversations with folks actually using the system and hearing from them and understanding what those challenges are, or what the great things are about the system. We'll talk a little more about that, but sometimes it's important to celebrate your wins. Several of these things are ones that I know, Jean, you guys have taken on and done some things with. So do you want to speak to some of those?
Yeah, I actually do, Heather. I'll start with that last one. So the overtime portion of user satisfaction over time is really important. It kind of leads me to say, in some cases, we tried to say, let's make sure we've got all the workflow down perfectly at go live. And I can tell you, while that's a good goal, I put a little caution there, because we had conversations 3 and 6 months after go live that we didn't know to have pre-go live, because we actually using the system is different, and what you learn about it is different than designing it for go live. So just be cautious about trying to be too perfect at go live. You got to have enough to get through encounters so clinicians and physicians can do their work, but you'll learn things about the system that you can say, you know what, if we go back and change that workflow or that design decisions, it'll help us. The other thing I would mention on the clinical outcomes and the data. So I think I'm a little fortunate, because my chief of staff at the time and my chief medical officer currently says, look, you get us data, but make sure that it's got integrity and you can defend it. Because what we're going to do as physicians, this is what we do, is we're going to challenge the data. The sooner, Jean, that we're able to get the data, challenge it, and understand that it's valid, the better off we're going to be. So let's get through that. Let's get over that hump sooner than later. And that's where your data and your clinical outcomes really get married together, because that's what you're going to show your physicians. And the change management Heather talked about, I can't emphasize that enough. So I'll make this quick, or try to. Small example, we could change the color of abnormal labs. My analyst can do that in seconds. And I got to tell you, I think in the first 3 months, we probably changed it, 10 or 12 times. Does someone call up and say, I really don't like the way that lab value is, can you change it to this color? And this is where the governance comes in. You've got to get the physicians together to say, we have to make a decision that's global, that affects everybody. And you want your physicians making those decisions, not your application analyst and your CIO. We shouldn't be deciding what abnormal labs look like. We need the clinicians to do that. This is all in that organizational will and that governance and that change management. Heather, that was my comment.
Yeah, perfect. I think that's a really important one. So one of the things that we suggest organizations go out and do is observe. So there's nothing like watching people use the system. The example that I'll use is I was in a very large physician practice, and I was observing some of the nurses use the actual system. And I would say that they'd had the system, I think, by the time we were there, 7 or 8 years. And they were fairly proficient in it. And yet there was a lot of random clicking to find things. I can't remember where that is, so I click in 3 places, and oh, now I see the menu that I'm looking for, and I click down. And they click very quickly, but the amount of productivity that's lost when a user doesn't understand the workflow or understand how to get to even functionality very quickly. So when we're looking at proficiency, we're actually looking at the ability to complete a task. And oftentimes we're even applying a time to that. And so this is just an example of how you might then display that information. There's folks in our organization on the ambulatory side that are doing great from a proficiency, or 70%, maybe they're on their way, they're not doing great. And then we have some real challenges when we look at 20% proficiency on the inpatient provider. But what this allows an organization to do is very quickly say, there's some places where we need to focus our attention. And then you move into where in the organization, so specific to tasks. View medication history. There are a few roles where there was just a lack of proficiency, and yet the nurses were doing great, right? So what this allows us to do is really focus in on the areas where there are some challenges. Oh, I'm sorry, I didn't mean to say that the nurses were doing great. I apologize, that's grayed out because it's not a task that they do. You can see down on inpatient RN where the P is, that indicates proficient. The NP indicates not proficient. And so across the organization, you can do these kinds of assessments throughout time to see how folks are doing, and it's very quantitative. I think one of the other things that happens often to us is we sit in our leadership meetings, and there's a lot of subjective I think, the nurses think, the physicians think, I heard. You know, and the truth is we do oftentimes hear from folks who are not doing as well as folks that are doing well, and so we get a bit of you know, a different perception about how this is going. But this quantitative data really allows us to have those critical conversations as a leadership team to say, this is exactly where we should focus. These are specific tasks. And then you can even take and relate them to, I'm going to move one more slide for us, to priority, to patient safety, to liability, productivity, and then an area of the organization. And so as we look at either system issues or things that are challenging with use of the system, we can very quickly then decide where to focus our attention based on these kinds of this kind of information. So again, fairly simple metrics. And I use that word because I think that simple sometimes is effective at driving some of the additional organizational changes that we have to do that are not as obvious when we started this journey. And maybe in healthcare, we just haven't been through quite enough of these iterations to truly understand what's needed there. Other areas where you would comment on this, Gene?
Yes, there are specifically. So you called it simple, and it is fairly simple. The important part is that someone does this. What will happen, is, and not just happen in my experience, but talking again to colleagues, is squeaky wheels, loudest person in the room, small sample sets, unfortunately tend to drive leadership's direction and decision. Quantitative data should drive it. So you'll have a group of employees, physicians, medical staff members, et cetera, who rightfully so are bringing up a topic, but because they've got the venue, the pedestal, the squeak wheel, or it's a small sample set, somebody will react. And that may not be the best and highest use of your resources. So I want to applaud Heather for pointing this out, because this is really important that you do it based on quantitative data and not, again, small sample sets and knee-jerk react, and therefore spend resources where they could be used elsewhere.
Yep, absolutely agreed. So the kinds of things that you'll want to be thinking about from an adoption assessment perspective, if this is something you're going to do as an organization, is governance structure and communication strategy. Is that in place? What does it look like? How are we doing it? How are we reaching the audiences we need to reach? Have we put in place a plan and a process for sustainable education? This is not an event, but an ongoing process. Productivity, you know, this is one of our biggest challenges in using systems, and maybe one of the areas where we have the most work to do. And that is, you know, really understanding workflow is what gets us to productivity. The most proficient users are the fastest users, for sure. So not, you know, trying to find something, but clearly understanding how a task gets completed using the system. The other indicator here for us is, you know, the system isn't the only thing we should be watching, and we get pretty focused on these systems, but the truth is that workflow begins oftentimes when a patient walks in the door. And there's other things that we have to be able to do, and understanding even the role of our colleagues is important in productivity and ensuring that we don't get slowed down by different things in the process. Quality and safety, of course, and then financial metrics. The thing that we've started doing, and I think really helps with this, is a roadmap for adoption. And so, you know, everything we do should be driven from a strategy level. And if we're thinking about adoption over time, there has to be a roadmap and things we're willing as an organization to say. We can't get all of these things done in the coming 6 months or even a year, but these are our highest priorities. And when we get through those, we're going to take a bite of the next chunk of these. And that really is the only way to make good progress, because it can be a bit overwhelming when you look at where you want to be versus where you are. And so, you know, really, again, a message that most people would say, I know that, but as you go in and talk to healthcare organizations and leaders, we lose sight of this very quickly. You know, whether the CEO or someone else is driving us to this project should be done. You know, we've got to do some education around what's possible this year and going forward. Gene and I are both, I guess, big fans of a concept that Jim Collins used called the stop doing list. And the stop doing list is about the things that you're not going to do. And it sometimes means making a list of things you're not going to do so that you can actually focus on your highest priorities. That's an exercise of discipline and important considering the many, many things that sit on our plate today in healthcare. Jean, I'll let you kind of comment too on the roadmap there and the other pieces.
Yeah, certainly. So I agree. You know, what we had to talk about a lot around here, and what I had to spend a lot of time working with people on, is that the acknowledgement that, you know, all resources, at least in this environment, are finite. So you've got to make sure you understand where you're going to apply those limited resources. And when you do a project like an EHR implementation, combine it with just the changing and evolution of healthcare, combine it with meaningful use in ICD-10, there's competing agendas. And so you have to have some way to have a process, preferably a specific process, of where we're going to deploy these resources. What's going to be on the stop doing list? Heather and I have talked about that from time to time, because there tends this tendency to want to do everything at once. People say, I can't stop this initiative. Well, you want to take a hard look at those things and decide which things do you want to pause. Sometimes it's best to tell people it's not no, it's just not now. And that's a really important, I think, component of this. One of the things that we did is, you know, we got about 9 months in and realized there's so many agendas and there's so many balls in the air, and we're all trying to make sure we can help people get through encounters, take care of patients with high quality, make sure to protect our financial performance. We had to get somebody from the outside to come in and kind of do a snapshot of where are we. You know, we may be too far in the weeds, we can't see the forest from the trees. Let's bring in some outside skill set and experience to kind of give us a snapshot as to where we are. We found that very beneficial in refocusing us on our governance and the best and highest use of those limited and finite resources. Heather, you may want to expand on that if you feel so inclined, but that's what we did. It actually helped us refocus. It's been very beneficial.
Yep, exactly. And I think doing this collaboratively, and you know, you guys came to the table and said we wanted do some of this work, and we said, you know, we do some of this work and we should be doing it together. I think as you and I both know, there are healthcare organizations that that are doing some of this on their own, and I also think that, you know, I'm a big advocate for publishing and literature because I think it allows us to share our learnings with others in healthcare organizations. But I do believe that sometimes having some of that work get done and help with perspective is important, as long as it's very collaborative and in the spirit of reinvesting in the organization and understanding what they're trying to get accomplished.
Yeah, you know, Heather, I'll comment, is when we brought the Breakaway Group in to do our assessment, if you will, just the touch point of about 100 individuals to get their perspective. I may have thought I understood where the perspective of the users were and the population of employees. To have an outside party sit with them, it's non-threatening, they speak openly, there's no bias, and there's actually no back and forth of, well, here's what I think. And that was beneficial for us. We got some fresh perspective that we otherwise would not have gotten.
Yeah, and you and I talked about sometimes that's a bit therapeutic even in the organization, and you know, as leaders, we're not always, you know, excited to admit some of that, but the truth is that sometimes we just have to take a breath and talk about where we are organizationally and use quantitative you know, information to make decisions going forward. But I also think that for Gulfport, one of the other important things was, as a leadership team and as even a management team throughout the organization and clinicians, you can't forget how hard people were working to do this. So there wasn't lack of effort, that's for darn sure. And I would say that across healthcare, it's one of the organizations where people just go work hard. It's amazing to watch. And yet, sometimes we don't pat ourselves on the back where we're doing a good job. And so there is also in this process some time to say, these are areas where we're doing well, and we have to keep doing them. And kudos to our people for doing this well. And there were even times when the users said, you know, the leadership team has done a good job at XYZ. You know, not that we're looking for pats on the back, but I think as an organization, you get pretty tired in this process, and it's nice to hear that there was some appreciation for some of the leadership efforts and some of the work that's been done to really move the ball in the organization. So Jean and I wanted to end with a reminder that adoption is never static. in an organization. It's dynamic. It's always changing. And just at the moment that you think you've got it all figured out, something can change in the organization. And I don't mean quickly, I just mean over time. So we often make the case that adoption is eroding when you're not paying close attention to it, how you lead it, how you educate folks, how you measure it, and your reinvestment in, the vendor product itself, and also the workflows and use of that product. And so, this is just a depiction, which is fairly easy to see and understand, of the user's actual proficiency to use the system. Fluency is essentially that level where we'd say the user can complete the task necessary to perform their job role. Optimization is typically where they can do that with a high degree of accuracy and productivity, so they're both fast and effective at using the system. This is a wonderful place to be. Very few organizations are here, and the truth is, if you're hovering in this area, you're probably doing very well and concentrating on some of the most important things. I love this danger zone. That's Jean's artistic addition to the process here, and it's true that right about here is where you're interested possibly in a new vendor or a new job or something like that, just to add a little humor to the process here. But Jean, you want to talk a little bit about that?
Yeah, I mean, the reason I kind of call that the danger zone is you get to this point where, okay, the trauma is somewhat behind you. People are using the system. We can get through encounters, like you said. Remember what physicians want to do. I want to place orders. I want to look at patient information. I want to do a diagnosis, and et cetera, et cetera. Maybe not in that order, of course. But once you get there, what you really want to do with these systems, because they are sophisticated and for good reason, if you really want to optimize your processes, eliminate waste, make sure that you can improve outcomes by having the right information at the point of care, do your analytics for clinical and business, you've got to continue on the path of constantly looking at the users using the system, implementing new processes or workflow that can get you better data, quicker information, better information for the physician. If you don't kind of have a sustainable process, you get into this danger zone where people get comfortable, and in some cases they work on workarounds. They figure out a way to short circuit, or that's probably the wrong way to say it, but to have workarounds, don't use the value and the intelligence clinical decision support of the system. So that danger zone is where people say, you know what, finally, we're back to our same volumes. My day's not as difficult. I can get through my encounters, and then you lose that fine-tuning that you need to stay focused on to make sure, it's kind of like race cars, you get those extra fractions of a second cut off each time around the lap. This is the danger zone. And people fall into categories of, I'm just not going to tweak it anymore, to what Heather said, which is, this has been too traumatic, I'm going to go do something else, or I'm just not going to really use the system the way they want me to, I'm going to use what works for me. And you get into that danger zone. I would apply some high caution.
Yep, absolutely. And also, I mean, back to the really positive message in this is that the truth is that it's much easier to stay right here than it is to recover from this place, which is the trough. And so, as leadership teams and organizations, we need to ensure that we're doing all the things to maintain the high level of adoption that we invested in prior to go live. So we invest a lot of time, money, and resources in that process, and paying close attention to it, or at least enough attention to it to maintain it, is easier work than recovering from something that's fallen off over months or years as far as the time frame. Because even getting those users back engaged and getting momentum around adoption is pretty challenging once you've gone the way of new habits and some changes in how we're using the system. So definitely time isn't our friend here, but absolutely the discipline to process is something that works well for adoption and needs some of our attention as leaders. So incredibly thankful for the time of the folks who joined us today. And also a big thanks to Jean and Gulfport, who continue to make a difference in healthcare, and we're appreciative to have had some experiences with them that have taught us a few more things about this journey of adoption. I think we're going to maybe open it up to questions, and Jean, I'll let you if there's anything else you wanted to say too for the ending of the presentation here.
No, I think it's all you know. This is a topic because it's so fresh, at least. And Heather, you know our experience with us being 15 months and 8 days. How I know exactly the time frame. And these are pretty fresh experiences, and we're still in the process of using the system to its fullest. You know, the comment I make is remember that you're taking care of patients when you go live. Back to what Heather said, when you go live, you're in a different environment than build and pre-go live because you're actually taking care of real patients using that tool, and it changes the dynamic. And so, you tend to start with how do we get through the encounters so we can get through the day, and you've got to have that will and that leadership to push through and constantly say we need to get the value out of the system that we anticipated getting, and it is a long journey.
Yep, absolutely. Lori, we'll turn this back over to you if there's questions.
Okay, thank you. Now we'd like to open it up to the audience for questions. As a reminder, please use the questions section on the GoToWebinar panel to submit your questions to Heather and Jean. It looks like the first question is for Jean. From your perspective, what was the biggest revelation after reviewing the results of the adoption assessment?
The biggest revelation for us was probably the lack of coordinated governance between, and obviously not critical of any party here, between our medical staff leadership, our C-suite, and my support staff. We're not quite as coordinated as we now are and were. When we went go live, we all kind of, it's not that we scattered, went our own separate ways. There are so many initiatives, so many balls in the air. I'd like to use the analogy of a bunch of bees swarming around your head from a beehive. There's so many things going on. It's very easy to become uncoordinated in your efforts. So the biggest thing we got was refocusing on what's important and what's the best and highest use of those limited resources.
All right, thanks. Heather, can you discuss the research approach used to conduct the on-site assessments at Memorial Hospital of Gulfport, and how did that relate to your earlier research on adoption?
Yeah, so some of the things we talked about a little earlier in the presentation around this challenge of electronic to electronic is we went back and looked at the key metrics that as we were talking to healthcare organizations, and they said, these are the differences between an organization that did well at adoption, and these are the kinds of activities and leadership that we had in organizations that were challenged. So we started at that leadership level. Did everything from coming in and observing folks with in every role doing and using the system, and have kind of a nice process for how we evaluate that and make it quantitative based on best practices and what we would expect in those workflows. Did some interviews which were a really nice narrative around what was going on in the organization, and Jean spoke a little bit to that. So we spoke to over 100 people, and we worked closely with Gulfport to identify the type of people that we wanted to speak with, and really got a pretty broad range of perspectives on what was going on in the organization. And then also did a pretty deep dive in what had been done from a governance perspective, communication, how some of the decisions had been made around the EHR. And we're thoughtful about how we analyzed that information, and then made some recommendations on what the goals were for the coming year and 2 years, and how the roadmap would actually align with that, and created that roadmap from the process. And then literally shared all of that information with Gulfport. I have to say one thing, and that is that I think sometimes organizations do assessments in some kind of goal to do more work specifically, and that was not our reasoning. Gulfport has done some of this work now themselves going forward, and we've given them the data and the information to do that. I'm a strong believer that you can't lead adoption for an organization. You can help them identify areas where they have weaknesses or blind spots, but they have to lead. And Jean can tell you that some of the work they're doing around governance and leadership is making a difference there today.
Thanks, Heather. That looks like it was our last question, so we'll conclude the webinar. Thank you all for joining us today, and thank you, Heather and Jean, for an informative presentation. Attendees, watch your email for links to the recording of today's webinar, as well as the PDF version of the PowerPoint presentation. We look forward to seeing you at our next HIS Talk webinar, and I wish you all a good rest of the day.